Yeah, so welcome to House. So this is on the introduction to MR spectroscopy, and so first principles and clinical applications. So here's an outline of my talk. So I give you an introduction into MR spectroscopy, then we talk about shielding effects and chemical shift, detectable metabolites and their significance, acquisition parameters, localization techniques. At the end I have a couple of clinical applications and then some future directions of spectroscopy. So why are we doing spectroscopy? Because it gives a glimpse into the neurochemical state of the brain that MRI is not able to provide. So we use it for diagnostics because metabolic changes in pathology that we can see by spectroscopy may not be apparent from anatomic images, and metabolic changes may precede anatomic changes. We use it to differentiate among different diseases, so there are different spectroscopic patterns for different tumor types, and also we are able to differentiate neoplasms from what we call MRI mimics. We use it to monitor therapeutic treatment because radiation necrosis and recurrence of tumor look the same on conventional images, but they're very different metabolically. And in addition, as I mentioned, metabolic changes precede anatomic changes. So often we can see if a patient responds to treatment earlier using spectroscopy compared to conventional images. And last but not least, we use spectroscopy to understand the pathogenesis of diseases. So if you just take a spectrum of the human body, of the brain, this is basically what you would see. So you see a huge water peak and you see fat. And they are basically resonating at different frequencies. In spectroscopy, we are not interested in fat or water. We are interested in all the different little metabolites that resonate between fat and water. But in order to see them, we have to avoid the lipids and we have to suppress the water. So the water is 10,000 times higher in concentration compared to any of our metabolites. So what we need to do is we need to suppress the water with a chemical saturation pulse, which is typically a 90-degree pulse on the water signal, and then you have a couple of spoiler gradients to get rid of the signal. That way you get suppression factors of 1,000 or sometimes 10,000, where now you can actually see all your little metabolites, and the peak is only maybe 10 times bigger than the NAA peak. And then what we show is we don't even show the water, we just show all the different metabolites. And I have a couple of slides what these metabolites actually mean in the brain. But first we need to understand, why do protons in different chemicals actually have slightly different MR frequencies? So why do lipids resonate at a different frequency compared to water? Because and why do all these different metabolites resonate at different frequencies? Because this is a frequency scale here. So because you probably learned before, the Lambda frequency depends on the gyromagnetic ratio and the external magnetic field. So during acquisition of our data, the external magnetic field is constant, so we don't apply any gradients. And the gyromagnetic ratio is also constant. We're only looking at protons. So why is it that we see many peaks and not just one? The reason is due to shielding of electrons around the nucleus. So the Lambda frequency, so the frequency of absorption, depends not only on the applied magnetic field, but in an effective magnetic field. And that effective magnetic field depends on the applied magnetic field, but also on the shielding constant. And every proton group experiences a slightly different effective magnetic field and therefore resonates at a different frequency. So every proton group has a slightly different shielding constant. So the frequency of absorption depends on the chemical environment of the nucleus. So the external magnetic field B0 induces a circulation in the electron cloud surrounding the nucleus such that a magnetic moment is induced, which is opposite to B0. So what does that mean? So you have your proton here in the middle, and then you have your electron cloud around it. And following Lenz's law, because this electron is in an applied magnetic field, it kind of circulates. And whenever you have a moving charged body in a magnetic field, it induces a magnetic field which is now opposite to the applied magnetic field. It's kind of like a diamagnetic effect. So now this proton feels a slightly different magnetic field than the applied magnetic field. It's not a huge effect, but it's definitely something we can measure. So electrons shield the nucleus from the magnetic field, and the effective magnetic field is always smaller than the applied magnetic field. And then you can imagine, if you have a lot of electrons around your nucleus, this effect is bigger than if you have few electrons around it. So let's consider this molecule methanol, so the easiest I could think of. I don't know if you remember from chemistry that oxygen had a high electronegativity. So it pulls the electrons further towards its side. So this proton has fewer electrons to shield, while carbon has not such a great electronegativity, so there's a lot of electrons around these protons. So which means these are better shielded, therefore they resonate at a lower field strength. This is why they also resonate at a lower frequency. So the shielding effect is proportional to the applied magnetic field, which makes it difficult to compare MR spectra taken on scanners operating in different field strengths. So the solution to this is now the chemical shift. So the chemical shift, or delta, is measured in parts per million relative to a reference compound. So it's the frequency of absorption minus our reference frequency divided by the reference frequency. And by designating the shift as a fraction of this reference frequency, which is proportional to the applied magnetic field, we make it field independent. So and the reference compound that the chemists at the time came up with was tetramethylsilane. So it's this molecule over here. It's very shielded. So silicon does have a very low electronegativity, so it does have carbon, so that's very shielded. So they arbitrarily put it to 0 ppm, and that makes now water always resonate at 4.7 ppm. And this is what we're using basically in our MR machines, because there's obviously no tetramethylsilane. So now basically everything is referenced. So another thing I want to point out, if you just look at this molecule over here, if you probably would have guessed that these 3 protons resonate over there because this peak is 3 times higher than this one. So the intensity of absorption, so the area under the peak, is proportional to the concentration of the nucleus. And that is still valid for comparisons between different molecules. So if I put like 50% ethanol and 50% methanol in a vial and put in a spectrometer, I do see a 50-50 peak, right? So you can basically, so this makes MR spectroscopy a quantitative tool. So the area of absorption gives you basically how much, what the concentration of your nucleus is. So let's talk actually about some of these metabolites and their significance, and predominantly in the brain. So this is N-Acetylaspartate, is this molecule, and is this methyl group that gives rise to a peak at 2 ppm. So it's in relatively high concentrations of 10 millimolar in the brain, and it's found in neurons in the adult brain. So therefore it's actually a marker for neural density and viability. It's a precursor for neurotransmitter N-Acetylaspartate glutamate. It participates in the formation of myelin lipids, and it also regulates osmosis. So whenever we see a decrease in NAA, it's typically associated with loss or injury of neurons. So in every neurodegenerative disease, NAA is actually decreased. Or when tissue is replaced by tumor tissue, so neurons are replaced by tumor tissue, it is decreased. It's decreased in hypoxia, demyelination. The only disease where it's actually increased is Canavan disease, and there the enzyme that breaks down N-Acetylaspartate into acetate and aspartate is missing, so you have this huge accumulation of NAA. So how do we know NAA is just in neurons? So way back when, 25 years ago, Oranjak did an experiment where he took just neurons and just astrocytes and took basically NMR spectra, and you see that NAA was only in neurons actually, and it was not in astrocytes. So another one that we can see is creatine. So when we talk about creatine, we actually mean phosphocreatine and creatine. And it's this methyl group that gives rise to a peak at 3 ppm, and these methylene groups give rise to peaks at 3.9 ppm, which we typically ignore. So creatine is a marker for energy metabolism, since phosphocreatine acts as a reservoir for the generation of ATP. And at a 1.5 and 3T system, we are not able to distinguish creatine from phosphocreatine. So we basically look at the sum. So therefore, it's often thought to be a good internal standard because we're looking at both creatine plus phosphocreatine. It's unchanged in most diseases and with age. However, it has been found to be decreased in high-grade astrocytomas and a couple of other diseases. So choline is an umbrella term for several soluble components of brain myelin and fluid cell membranes, including glycerol phosphocholine, and free choline. And all these methyl groups give rise to peaks at 2.3 ppm. So normally they're not very soluble, but pathological alteration in membrane turnover. So whenever you have a tumor, leukodystrophies, MS, results in massive increase in MR visible choline. basically makes it a diagnostic gold mine. And elevation in choline has also been seen in the developing brain as basically the brain myelinates. So this is how far we've gotten so far. We have NAA, highest peak, at 2 ppm, creatine at 3 ppm, and choline at 3.2 ppm. Choline and creatine are typically half the size of NAA. So if you could do this actually at 14 Tesla, you would actually see that choline is not just one peak. You just call it choline, but what it really is glycerylphosphorocholine plus phosphocholine and free choline. Okay, so lactate is a very important marker because it is actually, since it's produced by anaerobic metabolism. So it's this methyl group that actually gives rise to a doublet at 1.3 ppm. And if you have some time at the end, I will talk a little bit about what we call J-coupling and why we see doublets. So it's typically in very low concentrations in the brain. So, and this peak is inverted at 144 milliseconds due to this what we call spin-spin coupling or J-coupling, which is actually a good thing because if it's inverted, we can distinguish it from lipids, which also happen to resonate at 1.3 ppm. So as I said, an elevation in lactate is associated with anaerobic metabolism, so therefore it's found in tumors containing zones of necrosis, in hypoxia, infarction, mitochondrial diseases, and after seizures. So you should not be able to see lactate necessarily in a healthy brain. So whenever you do see lactate, typically for the radiologist, all alarms go on. So then lipids, I mentioned before, they also resonate, between 1.8 and 1.5 ppm, pretty broad peaks because, there are different types of lipids. They're associated with breakdown of tissue. So lipids indicate necrosis, which you have in brain tumors, but also after radiation necrosis. And it's seen in myelin destruction in MS, but you have to be careful. Sometimes you see lipids due to contamination from subcutaneous fat from the skull. So you always have to check where your voxel has actually been placed, which I will talk about later. Another one is Myo-Inositol. It's this sugar, and these protons give rise to a peak between 3.5 and 3.6 ppm. It can only be visualized with short echo times. And it's specifically in glial cells. It's not in neurons. So therefore an elevation may reflect gliosis, and it's also a proposed inflammatory marker. So it's an important marker in grading tumors because it has been found to be low in high-grade tumors and high in low-grade tumors, and also it's increased in Alzheimer's disease, which probably reflects the inflammatory process in Alzheimer's disease. And then we have glutamate and glutamine. So this is glutamate, and if you replace this oxygen with an amine group, you basically get glutamine. So they're very similar in structure. And they give peaks between 2.1 and 2.5 ppm. So we call them the left shoulder of NAA because NAA would be here, 2 ppm. So glutamate is an amino acid acting as an excitatory neurotransmitter. And glutamine is its precursor. And it's not possible to distinguish between glutamine and glutamate at 1.5 and 3 Tesla. For that, you probably have to go to 17. So this is our spectrum now. In the normal brain, white matter, semi-oval, 3 Tesla, 35 milliseconds. So NAA is our highest peak at 2 ppm. Then we have glutamine, glutamate over here, creatine at 3 ppm, choline 3.2 ppm, and Myo-Inositol at 3.5 ppm. So this is kind of the hunter's angle for the radiologist. So whenever you have like a 45-degree angle, so with the NAA being the highest, this is typically a healthy spectrum. If that hunter's angle is kind of pointing upside down, it's typically some pathology. But one thing you have to keep in mind is the brain is made of different cells, right? So you have neurons, astrocytes, oligodendrocytes, microglia, other immune cells, endothelial cells. So it is not surprising that there is regional variation in the brain. So in the white matter, as I said, NAA highest peak, choline, creatine half the size. In the pons, the NAA is already slightly lower. In the cerebellum, is absolutely normal if all 3 peaks are basically the same height. So let's talk about some of the acquisition parameters. So how do we actually get a spectrum, right? So like water, these metabolites have all their different T1s, and they happen to be about 1.5 seconds out of 1.5 Tesla. So if you wait 1.5 seconds, you get about 63% of your magnetization back. if you wait 3 seconds, you get about 85% of your magnetization back, and so on, right? So ideally, you want to wait as long as possible, more than 3 seconds. So here's an example where we took spectra with 1.5, 3 seconds and 4.5 seconds, and you do see that this exponential growth curve, right? So because the signal to noise improves and also quantification improves. So you don't want to have a T1 weighted spectrum or anything. However, if your TR is too long, the exam time increases, and we don't get all the time that we want on these machines, and especially in patients, right? So what we typically do is we get TRs of 1 to 3 seconds. And whatever study you start, just be consistent with, you know, the TR that you use for the rest of the study. More than T1, actually T2 has an effect on your spectrum. So lipids, Myo-Inositol, glutamine, glutamate, they have very short T2s. So they decay very fast. So Na, creatine, and choline don't decay as fast. So in short echo times, you basically still see everything. So you do see Myo-Inositol, glutamine, glutamate, lipids, and so on. If you go to longer echo times, some of these metabolites have already decayed, so including glutamate, glutamine, and Myo-Inositol, so you don't see that anymore. On the other hand, you have less baseline distortion, it's easier to process, and your lactate peak is inverted at 144 milliseconds. So that makes it easier to distinguish lipids from lactate, because lipids do not invert. So let's talk about localization techniques. So we have to be able to measure the MR spectrum. You know, we have to know where we place the voxel, right? So where the spectrum actually comes from. So that can be done with 2 different techniques. One is called single voxel spectroscopy. It uses selective excitation pulse to localize a relatively small voxel, and then there are also multi-voxel arrays that can be either obtained in 2 or also 3 dimensions. So in both cases, the first step is to excite a slice. So you have your patient in the scanner, then you apply a gradient, let's say along Z direction, right? So you get all these different frequencies along Z direction, and then you have a gradient, and then you have an RF pulse with a certain bandwidth that only applies to certain frequencies, and that basically gives you a certain slap in the brain, right? Exactly like you would do this in regular imaging. So what we do for single voxel spectroscopy, we basically do exactly that 3 times in a row. So we have an RF pulse with a gradient in X direction that gives you a slap in YZ. Then you have a second RF pulse with a gradient in Y direction that gives you a slap in XZ. So you end up with this rod over here. And then you have a third pulse with a gradient in Z direction that gives you a slap in XY. And where they intersect, this is exactly the voxel that you will excite in the brain. And this is what we typically do. It's called PRESS, point resolve spectroscopy. It uses a double spin echo with slice select. So you have some sort of water suppression in the beginning, and then you have a 90-degree pulse with a gradient in X direction, a 180-degree pulse with a gradient in Z direction, and a 180-degree pulse with a gradient in Y direction. And then you record your echo. And actually the gradient order can be absolutely arbitrary. You can start with Z or X, it doesn't really matter, as long as you have 3 pulses and 3 gradients. Where they intersect, this is exactly the voxel that you get. And if you just look for metabolic screening in kids that have developmental delay, let's say, so we place a 2 by 2 by 2 centimeter voxel, so they're pretty big, right? So we place one in the frontal cortex, one in the white matter semioval, and one in the basal ganglia. And then we see if there are any abnormalities. If we have a lesion, then we certainly place that single voxel on the lesion and always on the contralateral side. Or in temporal lobe epilepsy, you would then place these voxels in the hippocampus, on the left side, on the right side. So a way more efficient way to record the data is called magnetic resonance spectroscopic imaging, or chemical shift imaging, which can collect the spectra of a whole grid of many voxels at the same time. So that can be obtained in either 2 dimensions or even 3 dimensions, where you have a whole stack. And so normally the resolution is about 1 cubic centimeter. So, and you would do this certainly for tumors, right? So you have, this is a glioblastoma, and you see, you get the spectrum of the tumor, then you also see how far it actually infiltrates, and then you get the contralateral side also for free, all in one shot. So the CSI sequence is similar to any imaging sequence that you know. So the major difference is we cannot apply any readout gradient or frequency encoding gradient during data acquisition. Does anybody know why? So basically, if you put gradients on at the same time when you look at your data, you would wipe out all the frequency information where NA, choline, and creatine are, right? So that is all gone. So that's the whole point. We cannot do any gradient. So basically a frequency encoding gradient. So because we need the homogeneity to obtain the sharp peaks, right? So localization spectroscopy can only be implemented with slice selection and phase encoding. And then we can either look at the spectral maps, or we can look at individual voxels, or what some radiologists like these metabolite images. So the intensity displayed is proportional to particular metabolite signal strength. So in this case, this patient had a tumor, and we would look at choline, and you see the hot spots here in red. This is where the tumor is most aggressive. So some clinical applications. So we use spectroscopy in brain tumors, inborn errors of metabolism, ischemia, epilepsy, neurodegenerative diseases, and psychiatric diseases. And the order of which I'm mentioning them is not arbitrary, because in brain tumors and inborn errors of metabolism, the spectroscopic changes are large enough that they're of value in individual patients. So when we go to ischemia or epilepsy, so they're occasionally large enough that they may be useful for clinical management of some patients, but especially when you go to psychiatric diseases, you have very subtle changes. So if I'm looking at a spectrum of an autistic kid, I cannot see that he has autism, right? So this is not how it goes. So it's what you have to do is, they're more subtle, they're most meaningful in assessing groups of patients, and then do group statistics to look at changes, or look at the same patient to do serial MR spectroscopy, where you look at disease progression, or look at how they respond to treatment. So in brain tumors, so the evaluation of brain tumors is one of the areas where MR spectroscopy has impacted patient management, right? This was one of the first one that I mentioned. So MR can provide information of some of the key clinical questions, including the diagnosis, and I have a couple of examples, the grading of a tumor, distinguishing primary CNS neoplasms from metastases. So the choline peak, as I said, is a marker for neoplasm. And in primary CNS neoplasms, they're very infiltrative, so that choline basically degrades very slowly from the tumor into the normal tissue. In metastases, there's a very sharp edge. So there is choline, and then it looks normal. The choline is pretty much normal. So then we use it for therapeutic planning, for prognosis of patients, and also in therapeutic response and progression. So how does a spectrum look like in a tumor, right? So here's again normal side, NAA highest peak, choline, creatine half the size in the normal tissue. So in a tumor it's very different, and so these changes are not subtle, right? So you have this massive increase in choline, increased cellular turnover and accelerated membrane synthesis of rapidly dividing cancer cells lead to this increase in choline, which is a hallmark of brain cancers, in fact, of all cancers, so even in other in other tissues. Then you see typically a decrease in creatine. So most tumors are associated with a decrease in creatine, which is our energy metabolism marker. And then NAA, our marker for neuronal density and viability, is typically either decreased or completely absent, as tumor cells basically completely took over the neurons. Lactate is also an important marker. So as I said, it's this doublet, and it's produced by anaerobic glycolysis. So it occurs in highly metabolic lesions which have begun to outgrow their blood supply. So in this case, we had a kid with a medulloblastoma. It's 144 milliseconds, remember, so the lactate is inverted. And so you also see that choline is very high, and then creatine and NAA were very small. And then lipids are also important for brain tumors. So they are found in necrotic tissue, so either indicating high malignancy or also radiation necrosis in patients. So as I said, we use it to differentiate neoplasm from MRI mimic. So the choline over NAA ratio can be used to distinguish neoplasm from non-neoplastic brain masses, and also elevated lactate and lipids are typically seen with high-grade gliomas. So here's an example of a 7-year-old developmentally normal boy with sudden onset of right face and arm twitching, and now the AEG showed left parietal slowing and spikes. And so on the axial T2 and the coronal MP rate, you see a lesion basically here that appears largely isointense to gray matter and expands the parietal cortex. So there was no midline shift. It's isointense to gray matter. And it also didn't show any enhancement. So the question between cortical dysplasia and neoplasm was definitely favored by cortical dysplasia. So all the radiologists thought, okay, that's definitely a cortical dysplasia. The spectrum looked kind of interesting. So you have this high choline peak, right? And NAA is very small compared to the normal side. And in addition, you have a small lactate peak over the lesion. So only the spectrum was enough. So basically, they didn't believe the spectroscopy. They thought, oh, it's probably still cortical dysplasia, but at least the spectroscopy triggered that this patient gets close follow-up. So, and after a few months only, the lesion increased in size. So that could not be a cortical dysplasia, right? So that was 100% a neoplasm. So they went in with biopsy and they found it was an androcentric astrocytoma. So it's one of those cases where they should have listened to the spectroscopist in the first place. So, but pathology is still the gold standard for diagnosis, and biopsy is required to confirm the nature of the tumor whenever it's possible. But here maybe three-dimensional MRSI can help determine the most malignant part of a heterogeneously enhancing tumor. So here's an example of a patient, and you see hyperintensity on his FLAIR and T2 weighted images. There's enhancement on T1 post-gadolinium. There's an increase in cerebral blood volume, which typically indicates there's angiogenesis. And then we have these hot spots of choline, indicating that the tumor is probably most aggressive in these areas, and not so much here, where it's basically maybe kind of burned out, it's already necrosis. And then NA is completely gone here, right? So this happened to be a glioblastoma with oligodendral glioma components. So typical management for high-grade tumors always include resection first and then radiation therapy to include the peritumoral regions. And it's not uncommon that patients return with an enhancing mass near the resection site. And so now the question is it recurrent tumor, is it radiation necrosis, or something else? So if it's recurrent tumor, they definitely need additional surgery, right? So while you would not cut out radiation necrosis. So here's an example of a patient who had a glioblastoma that was resected, got radiation, and now he comes back and his brain looks like this. So there is hyperintensities on T2 weighted imaging and FLAIR. Then there is enhancement again on his T1 post-contrast images. And then the CBV is not very conclusive. So we did spectroscopy, and we find these massive elevation of choline even in non-enhancing regions of the brain. So this is certainly consistent with active cellular turnover and membrane metabolism. This patient in fact had recurrent tumor. Here's another example. It looks pretty much the same as I showed you before, right? So you have these hyperintensities on T2 and FLAIR. You see enhancement on T1 post-contrast weighted imaging, and then a pretty inconclusive cerebral blood volume. I don't know, maybe decrease, I don't know. Anyway, so MR spectroscopy shows lipids in this case. So the choline is not very high, and these massive amount of lipids indicate necrosis. So this patient, in fact, had radiation necrosis. So, but of course, these are the most clean-cut cases that I ever showed you, that I ever seen at MGH, right? So because elevated lipids have been detected in GBMs, and also radiation leads to inflammatory processes, which means that the choline becomes elevated also due to radiation. So what people found many years, like in 2002, is when we look at the choline over the enhancement side, over the creatine on the contralateral side. So if that was, in this case it was 1.3, was higher than 1.3, it was a tumor. So it was definitely recurrence of tumor as opposed to radiation change. If you just look at on one side, the choline over enhancement side over the creatine over the enhancement side, there's just basically too much overlap. So one thing that we learned is you always need to look at the contralateral side. Is choline elevated compared to the contralateral side? Is it just elevated compared to creatine on that side, right? So with the advent of anti-angiogenic therapy, it became basically very difficult to distinguish actual tumor response from pseudo-response. So, and what is pseudo-response? It's due to blood tumor barrier improvement that results in decreased contrast leakage in GBMs. So what does that mean? So here's an example of a patient who has recurrent glioblastoma. So it was already resected, it was radiated, chemotherapy, now it comes back. So one of the treatments these days is called bevacizumab. It's an anti-angiogenic treatment. It's also called Avastin. So with Avastin, actually 2 weeks afterwards, and I think Greg Sorensen showed 1 day afterwards, the enhancement is gone. So now what are you going to do? Because the radiologists 100% rely on T1 post-gadolinium images, right? So the tumor is gone on the images. However, the patient still progressed and died 7 months after the baseline scan. Here's another example. Patient with a recurrent glioblastoma now gets bevacizumab and also the enhancement goes away, but he survived more than 2 years after the baseline scan. So prognosis cannot really easily be done with T1 weighted imaging anymore. So I was involved in this RTOG trial in which bevacizumab was used in combination with cytotoxic agents, and we used contrast-enhanced T1 weighted imaging for the assessment for the 6 months progression-free survival. And the sub-study also performed advanced imaging, including spectroscopy, to gain insight into the tumor biology. And the question was, do early changes in spectroscopy correlate with patient outcome? So we had 123 patients with recurrent glioblastoma, however only 20 received spectroscopy, and then basically patients were scanned prior to treatment, and then at 2 weeks, 8 weeks post-treatment, and every 2 months after thereafter until the endpoint of the study, which was 2 years later. And everybody basically got bevacizumab and either temozolomide or irinotecan, so 2 different types of cytotoxic agents. And we had 13 patients that had an analyzable MR spectroscopic data set with a baseline scan because we wanted to look at changes from baseline. And here we are. So these are the NAA over choline changes in the tumor. It looks pretty busy, but you remember, so NAA is the marker for neural health and choline is the marker for tumors. So if it goes up, it's a good sign, right? So it looked like at 2 weeks it all went up, and then it went pretty much all over the place. So when we now distinguish between progression-free survivors and non-progression-free survivors, it looks a bit cleaner. So we, at 2 weeks still, everybody kind of responds to the treatment. So the NAA over choline goes up. But then at 8 weeks, we are able to distinguish, based on our NAA over choline signal, if they're progression-free survivors and if they're not progression-free survivors. So all patients who showed a decrease in NAA over choline had unfavorable outcome. Another example is where spectroscopy is very helpful is in pediatric brain disorders, right? So in inborn errors of metabolism. So these include either leukodystrophies, mitochondrial diseases, or some enzyme defect that either cause the absence or the accumulation of metabolites. But one thing that you need to know is when the spectrum changes very rapidly in the first 10 years of your life. When you're born, your NAA is very low and your creatine is also still low. So Myo-Inositol and choline are actually pretty high. And as you mature and the neurons mature, your NAA actually slowly goes up, and so does creatine, and Myo-Inositol and choline go basically down.
Okay, but when you're quantifying these peaks, do you take the peak value of the real part, or do you integrate the peak?
The real part. It's the area under the real part that.
The area.
corresponds to your concentration. Yeah.
So you have to define the limits of that integral.
Yeah, so there are, there are tons of analysis programs, including LC model or JMRUI, Tarquin. So there's tons of analysis programs to do this. An LC model is only $15,000. But we have a version. So anyway, yeah, it's basically it's the area under the curve that you want, right? You can do it in MATLAB too. It's just, yeah. So one of the diseases we looked at is adrenoleukodystrophy. It's a genetic neurodegenerative disorder which leads to the accumulation of very long-chain fatty acids. So there's an acute form in the childhood which leads to inflammatory demyelination, neurological dysfunction, vegetative state, and often death. So it's a very devastating disease. And then there's a chronic form in the adulthood which leads to axonal loss in the spinal cord. However, sometimes these patients also have demyelinating lesions, and it's not possible to predict the phenotype by mutation analysis or biochemical assays. So the same mutation leads to these different things. So MRI is very good in depicting the demyelinating lesion. It's typically extending from the splenium symmetrically into the periventricular white matter. Sometimes it starts in the geno. But spectroscopy is good for predicting lesion progression. So they did spectroscopy in what they call the juxtalesional regions. So it's still normal appearing white matter, but it's not but very close to the lesion. So when this looks normal, it's typically a good sign. If you see choline already being elevated and NAA being down, it typically led to a more progressive disease. So while this patient was non-progressive, this one was progressive, and that's 3 months later. So another disease, so here 21 months old boy born without complications after uncomplicated pregnancy, failed to achieve unexpected developmental milestones, developed nystagmus, poor muscular head control, physical examination showed generalized hypotonia and macrocephaly. So here's the spectrum. So can anybody say what this is? There was one disease where NAA was increased, right? And that was Canavan disease. So this patient had Canavan disease, and this is the mutation in which the enzyme that breaks down NAA into acetate and aspartate is missing. So this leads to a huge accumulation of NAA. So here's an example of a 2.5-year-old child with mental retardation, seizures, and speech delay. And here is the spectrum. So this is NAA. This is choline. So what's missing? Creatine, right? So so it's a slam dunk diagnosis right there, right? So creatine missing, creatine deficiency. And there are certain creatine deficiencies that can be treated. And by the way, on the MR image, you would not see this, right? So so after 3 months of supplementation of creatine monohydrate, patient is clinically improved and the creatine is back. So some future directions. So like no other imaging technique, spectroscopy really suffers from low signal to noise, because the even NAA or glutamate, they are in like 10 millimolar concentrations, are still 10,000 times lower than the water peak, right? So there's certainly a need to go to high field strengths for better signal to noise, or shorter scan times, better spatial resolution, and also higher spectral resolution. So here's an example of spectra obtained at 1.53 T and 70, and the signal depends on how many spins you acquire, the gyrometric ratio, which you cannot do anything about, and the magnetic field strength. So it linearly should go up with field strength, and you actually see that the noise decreases. The other thing is spatial resolution. So we can make our voxels smaller. So normally for MRSI we used 1 cubic centimeter. So we started a collaboration with Oded Gonen from NYU and implemented a 3-dimensional MRSI pulse sequence on the 70 with like 16 by 16 phase encoding, and then it had this Hadamard encoding in Z direction. So the isotropic spatial resolution was 0.375 centimeter. So one box is 0.05 cubic centimeter, and that was done in 25 minutes. And despite this very high resolution of a 50 microliter kind of voxel, the signal to noise was still good enough to make out NAA, choline and creatine very well, and so you actually see the underlying anatomy of the monkey in this case. And my last slide basically is you can also have increased spatial resolution if you go to higher field strengths. So the ppm scale is always the same. It always goes from 0 to 4 ppm that we're interested in, right? But now all the metabolites are stretched out on a much higher frequency scale. Instead of being cramped on 500 hertz, now they are actually distributed on 2000 hertz. So now you can actually distinguish glutamine from glutamate. You see aspartate, you see taurine, you see that Myo-Inositol is not just one peak, it's actually this triplet, and this is actually doublets of doublets. So it's way easier to analyze. And as I said, so now also, you know, in psychiatric diseases where you're interested in just glutamate, it's definitely the way to go to higher field strength. So this is all I have for this. If we have some extra time, I'm happy to talk about J-coupling, if you're still up for it. All right.
Thanks so much, Ava. That was great. Yeah, if you guys have questions, please feel free.
Exactly. Good questions.